Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 434 of our pharmacotherapy series, which majors in breast cancer. The next case reads, CDC, a 37-year-old woman, is found to have a 2.2 cm mass in the outer quadrant of her right breast during a mammogram. All of her laboratory values were normal, and her chest X-ray was negative. Her family history is significant in that her mother died of breast cancer at the age of 42 years and her 44-year-old sister had a breast tumor removed 5 years ago. So my question to you reads, with CDC's family history, what genetic testing could be performed for her or for anyone else in her family? If CDC did not have a family history of breast cancer, what other tests could be conducted to estimate her risk of developing breast cancer? CDC has 2 first-degree relatives with early-age breast cancer. This would indicate a possible inherited genetic mutation. Genetic testing for the presence of BRCA1 and BRCA2 mutations should be discussed with CDC by the age of 70. A person with a BRCA1 mutation has an approximately 60% risk of developing breast cancer and a 40% risk of developing ovarian cancer. BRCA2 mutation carriers have a slightly lower risk of breast cancer, that is approximately 40%, and a lower risk of developing ovarian cancer, that is approximately 20%. One population with a high incidence of BRCA mutations is those of Ashkenazi Jewish descent, where 1 in 50 individuals are BRCA carriers. CDC should meet with a genetic counselor to discuss risks and benefits of genetic testing for her and her family members. The results would then play a role in future screening and preventive strategies. Patients can assess their risk of developing breast cancer by using validated risk tools. One such instrument for average-risk patients is the Gale model, which takes into account numerous factors such as age at menarche, age of first live birth, presence of atypical hyperplasia, and number of previous breast biopsies. This model is available online. www.cancer.gov/bcrisktool/. Other models that have been validated include BRCA-PRO and the Breast Cancer Risk Assessment Tool, for average-risk patients. BRCA-PRO is a statistical program that uses information from both affected and unaffected relatives to predict the likelihood if a person would have an inherited mutation in BRCA1 or BRCA2. This tool would be used in an individual with a high risk of developing breast cancer. There are numerous resources for patients and family members to help understand their risk of developing breast cancer. Concerned individuals should have a conversation with their physician regarding their risk of breast cancer and the utility of these risk assessment tools based on their personal and family history. The next question reads, what are the typical signs and symptoms of breast cancer, and does CDC have any? Typical presentation involves the identification of a painless lump on clinical examination by a healthcare professional, by the patient, or by visualization of a painless lump on mammography. Other symptoms are nipple discharge or retraction, or skin changes of the breast. Less than 10% of patients will present with metastatic disease. Symptoms upon presentation can reflect their metastatic disease, i.e., back pain, bone metastases, headaches or nausea or vomiting, brain metastases, dyspnea, lung metastases, or abdominal pain, or liver metastases. CDC had a painless lump identified on mammogram as her presenting sign. My next question to you reads, after the identification of CDC's breast mass on mammogram, what diagnostic procedures should be done to determine CDC's type and stage of breast cancer? Workup for breast cancer includes radiographic examinations, patient history, and a physical examination. If a mass is palpated, a mammogram is completed to identify the abnormality. A breast ultrasound can also be added after the mammogram to differentiate fluid-filled cysts, which are usually benign, versus discrete masses. Once identified, a biopsy would then be performed to diagnose the disease. This is achieved with a core biopsy, the standard method used to obtain a tissue sample. This procedure uses a large bore needle for tissue collection and allows for distinguishing invasive versus non-invasive disease. Other methods are available for tissue diagnosis such as fine needle aspiration and excisional biopsy, but the core biopsy is considered the standard approach. Full radiologic testing should also be completed, including a CT scan of the chest, abdomen, and pelvis, and bone scan to assess for metastatic disease. The most common places for breast cancer to metastasize are the bone, lung, liver, lymph nodes, and the brain. Evaluation for brain metastases will usually be performed if the patient is experiencing signs and symptoms such as blurry or double vision, uncontrolled nausea or vomiting, headaches, and unsteady gait. These tests are used to determine the extent and stage of the disease and ultimately help determine the prognosis and treatment of the patient. CDC will need to undergo a biopsy and full staging with a CT scan of the chest, abdomen, and pelvis, and a bone scan. My next question to you reads, CDC had a core biopsy performed which revealed invasive, or infiltrating, ductal carcinoma, abbreviated as IDC. Other staging tests included a CT scan of the chest, abdomen, and pelvis and a bone scan. All tests were negative. Physical examination revealed ipsilateral lymph node involvement. Mammogram revealed a 2.2 cm mass in the right breast. So my question to you is, What are the common types of breast cancer and what stage is CDC's breast cancer? The histology of breast cancer is typically divided into two categories: invasive and non-invasive, in situ, disease. Invasive, or infiltrating, ductal carcinoma is the most common type found, in approximately 75% of cases, and invasive lobular carcinoma, abbreviated as ILC, is second, in approximately 5% to 10%. The non-invasive tumors are less common: DCIS and LCIS, ductal carcinoma in situ and lobular carcinoma in situ, respectively. Other less common histologies include medullary, mucinous, tubular, and papillary. One of the most aggressive forms of breast cancer is inflammatory breast cancer, which is distinctly different from the other types of breast cancer mentioned. Breast cancer can take years to develop into a mass that is identifiable on physical examination or mammogram. In contrast, the onset of inflammatory breast cancer is sudden and can develop in weeks. Presentation includes a breast that looks inflamed, red, and has the look of an orange peel, peau d'orange. The diagnosis may be delayed because the skin has the appearance of cellulitis with antibiotics prescribed first. However, the symptoms do not improve with treatment. Staging is conducted to evaluate the extent of disease. This is completed to understand a patient's prognosis and to help to determine the best treatment course. Staging of breast cancer is determined using the TNM, with T denoting tumor size, N denoting nodal status, and M denoting any site of metastatic disease classification. This information is determined by both clinical and pathologic examination. In 2010, the breast cancer staging system was updated by the American Joint Commission on Cancer. Stage 1 disease involves small tumors, that is less than 2 centimeters, with no lymph node involvement and is highly curable with approximately 98% 5-year survival. Stage 2 includes small tumors with lymph node involvement or larger tumors, that is greater than 2 centimeters and equal to or less than 5 centimeters, with no lymph node involvement. Stage 3 tumors are larger, greater than 5 centimeters, with lymph node involvement with a 5-year survival of approximately 80%. Stage 4 disease has metastasized to other distant organs and has the poorest prognosis with a 5-year survival of approximately 26%. Most patients will present with stage 1 or 2 disease due to routine screening. Based on CDC's clinical staging, she is considered to have stage 2 disease based on the size of her disease and the involvement of ipsilateral lymph nodes. Further pathologic analysis of CDC's breast tumor reveals estrogen receptor, abbreviated as ER, positive, and progesterone receptor, abbreviated as PR, positive disease. Human epidermal growth factor receptor, abbreviated as HER2, testing of the tumor was negative. So my question to you reads: what routine prognostic factors are evaluated in all breast cancer patients? In addition to staging, Other prognostic factors should be evaluated to help determine a patient's treatment course. Prognostic factors such as size of the tumor and lymph node status are important. A larger tumor size denotes a poorer prognosis than a smaller tumor size, and the presence of disease in the lymph nodes leads to a poorer prognosis than lymph node negative disease. Further, presence of a high number of positive lymph nodes is directly related to a poorer prognosis. Pathologic testing of the breast tumor gives important prognostic factors such as estrogen receptor and progesterone receptor and HER2 status. Tumors that are estrogen receptor or PR positive tend to denote a slower growing, indolent disease and have a more favorable prognosis than estrogen receptor and or progesterone receptor negative disease. Approximately 2/3 of breast cancer patients diagnosed have estrogen receptor and or progesterone receptor positive disease. If a patient has estrogen receptor and or progesterone receptor positive disease, hormonal therapy is a treatment option. Tumors that are HER2 positive generally denote more aggressive disease. Approximately 25% of breast cancers test positive for HER2 gene amplification. Although this is indicative of a more aggressive disease, it is a positive predictor for response to trastuzumab. HER2 positivity is determined by two different methods: immunohistochemistry or fluorescence in situ hybridization, FISH. Either method could be used to determine HER2 status. Immunohistochemistry determines the overexpression of the HER2 protein, and results are reported as 1+, 2+, and 3+. Patients with 3+ overexpression are considered positive for HER2 and will respond to trastuzumab therapy or other HER2 targeted therapies. If a patient is determined to have 2+ overexpression, an equivocal test, then further testing would be conducted with fluorescence in situ hybridization. Fluorescence in situ hybridization testing evaluates the HER2 gene amplification by denoting a ratio of the number of gene copies of HER2 compared to the control, and only those patients with positive fluorescence in situ hybridization testing will respond to HER2 targeted therapies. Other pathologic tests are completed such as nuclear grade, which determines the degree of differentiation of the tumor cells, as well as tests to evaluate the growth fraction of the disease, such as S-phase fraction, Ki-67, and mitotic index. Clinicians use all of these factors, positive and negative, to determine a patient's prognosis and treatment course. Other tools allow clinicians to take a more individualized approach, i.e., hormonal therapy alone, chemotherapy alone, or a combination of chemotherapy and hormonal therapy, to treatment. One such tool is Adjuvant Online, www.adjuvantonline.com, which can be used in early-stage breast cancer patients after surgery to evaluate their individual risk factors and determine treatment benefit versus risk of recurrence. This tool uses clinical factors to estimate an individual's % risk reduction in recurrence after adjuvant treatment, the benefit with hormonal therapy alone versus the benefit of hormonal therapy and chemotherapy. In addition, genetic profiling has led to the creation of gene arrays to evaluate a patient's risk of recurrence based on their treatment course. Many patients today present with early-stage disease, which is highly curable. Clinicians can use these tests to determine which patients should receive more or less therapy based on their recurrence score. One such test is the Oncotype DX assay for patients with estrogen receptor and/or progesterone receptor positive and lymph node negative disease and assigns a patient a recurrence score. Based on the score, clinicians and patients can decide the best treatment course, such as hormonal therapy alone versus the combination of hormonal therapy and chemotherapy. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 435.